Hi, I'm Ankita Sen. Welcome to my channel Nursing Sensation. In previous video, I have discussed about a very commonest medical conditions of India and globally, that is iron deficiency anemia. In previous video, I have discussed about what is anemia, what are the incidental rate of anemia, what are the occurrence rate of anemia. What do you mean by iron deficiency anemia? What are the types? What are the pathophysiology? What are the causes of anemia? What are the risk factor? How we are grading the anemia as per the WHO, CDC, ICMR, and what are the sites where we are checking for the pallor or the signs of anemia. So these all I have discussed in my previous video. To watch that video, click on this I button. Even I can give the link in the description box where you can go and click and see my previous video. In today's video, I'm going to continue the topic as because I'm going to discuss about in a very detailed form about the management in a dietary form, the medicines what you can give, okay, about the parenteral therapy of iron and the blood transfusion, and most importantly the prevention of anemia and the role of nurse or a role of midwife. Now come to the most important part, that is the management. So first I will discuss about the management, then I'll go for the prevention. So first I will discuss about the management. So how we can manage this during the early pregnancy? We can manage by diet or the oral iron therapy. In the late pregnancy, we have to manage by the parenteral iron supplement or by the blood transfusion. Okay, so what type of food we can give? We can give the iron-rich food along with the vitamin C-rich food to prevent the anemia during the pregnancy or pre-pregnant women also, okay, in the adolescence period. Then we can use the iron utensils when we're cooking, okay. These all are points what we are saying is during the pregnancy or before the pregnancy. In every normal persons also, they should use the iron utensils and they should cover when they are cooking the iron rich food or the foods they are cooking, so that the iron will not destroy it. So use the iron utensils when you are cooking and covered it, okay. Then deworming. So during pregnancy we have to go for the deworming, or before pregnancy you have to go for the deworming as a prophylaxis or the prevention of anemia, okay. So these are the things we can go for. But here is also some things like factor which is influencing or barrier in this management on the prevention. What are that? Like the cause of anemia. If it is simply iron deficiency anemia, we can treat by any ways. But if it is not iron deficiency anemia, other causes like sickle cell or aplastic cell anemia, or continuously hemorrhagic anemia in by any means, that cannot be prevented instantly or by 1 and 2 months during the pregnancy. So this depends the factor influencing for the management and the prevention also as per their cause. Then types of anemia, what I have said right now. Then if the iron deficiency anemia is there, so you have to check the severity, how it is. Okay, what is the severity level of iron deficiency anemia? Then associated complications. What are the associated complications factor? Either it's a problem in the iron intake, or it's a problem in the iron absorption, or it's a problem in the cooking process, or in the problem in the taking process of the iron. If there is no vitamin C or not proper time to take the supplements, the woman is not taking the supplements in a proper time, so there are some barriers in the absorption. So thus we have to understand the associated complications which are barrier. So what may be the iron-rich diet as per our food chart? We can go for the pomegranates, we can go for the berries. Okay, pomegranate in Indian scenario is very common to get. It's very easily accessible, or is very available. If somebody is getting berries, these are the best food we can see, okay. But in Indian scenario, we are saying that the pomegranate is the substitute of berries, so you can go for the pomegranates, okay. But you have to take it in a moderate way. Then you can go for peach, you can go for raisin, you can go for apple, you can go for dates, figs, you can go for strawberries, you can go for plum, you can go for any fruits Okay, citric fruits, citrus food. You can go for dark chocolate, broccoli, meat. Okay, you can go for pumpkin seed, tofu, whole grains, pulses, legumes, green leafy vegetables, spinach. So these all are the good QE, good source of iron rich diet in our Indian food. Okay, and second one I have told you about the cooking. We have to cook in a iron utensils by covering when you are cooking. Then deworming. Now discuss about the deworming. How we can do that? WHO is recommending that single dose of albendazole for 400 mg we can give to the pregnant woman after 14 to 16 weeks of her gestation. If we are giving mebendazole, we can give 500 mg. So how we have to take the albendazole? Albendazole is recommending 400 mg, one tab at the bedtime after your meal. When the woman is going to the bed, the woman has to chew, or the woman has to chew, and the woman has to take the tablets. It should not be take with the water and swallow. Okay, if the woman is taking mebendazole, you can give the mebendazole 100 mg twice a day. That means in a day we are giving 200 mg. Okay, 100 mg twice a day. You have to give mebendazole for 3 days. In that case, the woman is getting 600 mg of mebendazole as a deworming or the prophylaxis or the treatment of hookworm infestations. Okay, so it should not be give any woman during the first trimester. You have to give in after 14 to 16 weeks of gestation. Okay, now come to the iron supplement. What I have told you, without iron supplement, we can't meet the iron demand during the pregnancy. It's not at all possible. So the National Iron Plus Initiative is recommending 100 mg of elemental iron and 500 mcg of folic acid daily for 100 days. It has to be taken after 14 weeks of gestation in the pregnancy. Okay, same dose has to be taken again 100 days in a postpartum period. So when the baby is getting born, for again 3 months or 100 days, the woman has to take the same dose of 100 mg of elemental iron and 500 mcg of folic acid to prevent the anemia. Okay, so these are the supplement. So supplement again you have to take in a proper way. I will discuss that. Now the treatment of iron deficiency anemia, WHO is saying that 120 mg of iron, elemental iron, okay, they have to take per day. Okay, our recommendation is saying 100 and WHO is saying 120. Okay, and WHO is saying it has to be taken in empty stomach or 1 hour after the meal. It's better to take in empty stomach. I will explain you why it's better to take in empty stomach. But if someone is having nauseatic in feelings, the woman can take 1 hour after the 1 or 2 hour after the meal. Okay, for the better absorption, because full stomach is a inhibitor for iron absorption. So you have to wait for at least 2 hours. Preferably, it has to be taken with vitamin C food. So what we are recommending? Consume any any vitamin C rich food throughout the day. Or it's better to take your iron tablet with a half cup of water with few drops of lemon, and you can consume the tablets with this lemon water. So it will help your body to absorb the iron properly. Or else you can take it empty stomach, because empty stomach is an acidic environment. Okay, again there is a HCG is there, so empty stomach will also help to increase the iron absorption. So how you can understand the woman is taking the iron tablet every day? There is no dropout or way out of the iron intake. So you have to very trickily you have to ask the woman that how you are passing your stool. Are you passing your stool every day? If she is saying yes, I am passing the stool every day, next question should be, what is the color of your stool? If she is saying it is blackish in color, little bit, it's not yellowish like previous. So you have to understand she is taking everyday iron tablet, iron, calcium, iron and folic acid supplement, because as a side effect of iron and calcium supplement, the color of stool is getting changed. There is nothing to worry about. So this is one tricks to understand she is taking the iron and folic acid every day or not. Now I will discuss about some enhancer which help in the iron absorption. So you have to know that to counsel a woman. So like protein, any meat, ascorbic acid, any vitamin C rich food, amla, kiwi, lemon, orange, guava, anything which is having ascorbic acid, the woman should take it as an enhancer. Ferrous iron, gastric acid, alcohol, though I will not recommend to take that alcohol. Then increase the erythropoietic activity. These are the heme iron, these are the enhancer for the iron absorption. But at the same time, there are some inhibitor like full stomach. If there is a full stomach, this is inhibitor for iron absorption. You should not take much more phytate rich food. Our Indian food are more rich in phytates, which is inhibitor. Then calcium, tea and coffee. That's why we are saying when you are taking iron tablet, at least maintain 4 hour gap between before taking your calcium supplement. So we are saying calcium supplement has to take 2 times after the lunch and after the dinner, so that there is a long distance or gap between the iron and folic acid and the calcium, because this calcium is an inhibitor for iron absorption. So when you are taking any iron tablets in the morning, after that you should not take any milk or dietary product, so that it will reduce the iron absorption. Okay, so not only calcium supplement, you have to think about what are the source of calcium that you should not take at least 2 to 3 hours when you are taking the iron tab and the folic acid tablet. Understood? And tea and coffee also inhibitor. Now come to the side effect. What are the gastrointestinal side effect can happen? Nausea, gastritis, constipation, indigestion, diarrhea sometimes can happen. The woman can drop out from the iron and folic acid intake. Okay, as it has to be taken in every day. Sometimes the women are forget to take, or they are, when they are remembering, they are taking. Maybe that time she is on a full stomach, or she has just taken a glass of milk, or just she has taken a full plate of paneer or chena, and then she has taken, she has just wondering that she has not taken the tablet, and she just consume her tablet, so it will not work. Okay, so this also the some side effects of iron and folic acid consumptions. Then if there is a reduced dose, somebody has reduces the doses, or somebody has changed the brand, or the preparation has changed. Okay, that also influence the side effects and the absorption both. Okay, so these are the things. So when the women are taking the iron orally, it will not suddenly increase. So how it will increase? It will increase in a 5 to 7 days. It will increase the 0.2% per day. That is the reticulocyte count will increase. In 2 to 3 weeks, you can see 0.8 to 1 gram per DL per week. The MCB and the hemoglobin all will be increased. On the 6 to 8 weeks, you can see the hemoglobin comes to the normal range almost. So it will take almost 1.5 months to 2 months to get its normal state if you are finding any woman in an anemic state. So to wait, okay, and then you have to go for the test again to rule out she is still anemic or not. Till then you can check clinically, definitely. Now come to the postpartum prophylaxis. So how postpartumly we can reduce or prevent the anemia, because during the birth time, either C-section or normal birth, there is a huge blood loss. So for non-anemic women who is non-anemic, for them WHO is saying 60 mg of elementary iron per day for for 3 months or the 100 days. Ministry of Health of India is saying that 100 mg of elemental iron per day for 6 months. Okay, for mild anemic, they are saying that 100 to 200 mg per day of elemental iron should be taken for 3 months per day. So these are the for postpartum prophylaxis, or for the postpartum mild anemic women. Now come to the management. That is, I have told you management on diet, on food, on deworming, how to cook, the lifestyle modification, the cooking process. Now I will go through the supplementary I have also discussed about with you. Now I'll go through the parenteral iron preparation of the supplement. We can give the intramuscular, that is dextran injection, which is not right now recommended because it's too much painful and having side effects and abscess are more. So now we are going for the intravenous, that is iron sucrose. Okay, so here you can see how you can give iron sucrose. So here I am giving you one formula here by which you can easily understand how to calculate how much iron the woman has to be infused by the intravenous. So go through this drug calculations, how to do this requirements of iron, and then you can understand the dose of the iron supplement for the woman. Okay. If we are giving iron sucrose, generally we are giving 200 mg of IV iron sucrose over 15 to 20 minutes in 200 ml of normal saline. So it's a one-day procedure. You can say it's a day-based care procedure. The women are coming in a daycare. They can take twice in a week. We are giving, okay, we are giving a 200 ml of NS over 15 to 20 minutes, and the woman can take and she can go home. Now there is a new preparation of iron supplementary in a intravenous form, that is ferric carboxymiltose, where there is a new preparation of iron and there is a no dextrose, so there is a very less of side effects. So why we are going for the parenteral iron therapy? Why? Because I am giving the oral therapy, then why to go for? Because see, when the woman is a second or the third trimester, we don't have time to treat her orally, because I have told you orally the iron will take almost 1.5 and 2 months to get it normal range. So during the third trimester or before 34, 36 weeks of gestation, if the women are coming, so we are not having time in our hand to treat orally. So to go for the parenteral. Okay. So why we are going for the parenteral iron therapy? Okay. Why? What is the indication of that? Is very easily you can understand. When the woman is not able to take orally, or there is a problem to oral intake, we can go for the parenteral. You are very correct. So what are the side effects? What I have said right now, that is nausea and vomiting. When the woman is saying that I am feeling nauseatic or I am vomit after every pills of my IFA tablets, so there is an intolerance, oral intolerance of IFA calcium, IFA tablets. Okay, so you have to go for the parenteral. When there is non-compliance, failure to iron therapy. I mean, when you are giving the iron therapy, still the hemoglobin level is not getting rises or getting up. Maybe there is some undiagnosed, undertreated causes, untreated causes. So that is one cause. Okay, second cause. Then there is if there is a malabsorption, if there is any celiac disease or any bowel disease which can lead to the malabsorption in the duodenum or the proximal jejunum. So that can also lead to the indications of parenteral iron. Then in the late second and third trimester with the moderate to severe, what I have said right now, in the second trimester or the third trimester, late second and third trimester, we don't have any time to wait for 1.5 months to recover in the normal stage by the oral therapy. So you have to go for the iron parenteral therapy. Okay, in case of moderate to severe postpartum anemia, when the mother has to go home and she has to give breastfeeding, but she is lethargic, palpitation, breathlessness is there, so you have to recover the mother immediately. So you're going for the IB sucrose or iron sucrose, or you're going for the blood transfusion. Okay, so these are the common indications for the parenteral iron therapy. So highest dose we can give is 1000 mg at a time. Okay, and that test is no need to go for any test before giving to the infusion, iron infusion. Okay, so postpartum anemia also, still it is approved for postpartum anemia. Still it is not approved in the pregnancy, as it is category C of drug. It is means what I am saying about, it is ferric carboxymiltose, which is a new preparation of IB iron. Okay, so this is not recommending still in pregnancy. In pregnancy, iron sucrose is recommended, but postpartum period, these both are recommended. Okay, now come to the last point of management, that is blood transfusion. So what are the indications for blood transfusion? So WH is saying that elective elusives, when there is a planned elusives like history of APH previously and the woman is going for the cesarean section, there is a PPH history previously, there is a previous history of cesarean section where the hemoglobin between 8 to 10 gram percentage. So beforehand, in these cases of elective elusives, we have to keep the blood ready in hand for the transfusions. Okay, one unit has to be cross matched and keep ready in hand. If the hemoglobin is less than 8 gram percentage, two unit has to be cross-matched and ready in hand in case of electrophysiology as per the WHO. Now, in case of antenatal period, when the pregnancy is less than 34 weeks of pregnancy and the hemoglobin level is less than 5 gram percentage without any signs of cardiac failure or hypoxia, that time we have to go for the blood transfusion as per the FOGSI, that is FOGSI, FOGSI. They are saying if the pregnancy is more than 34 weeks of gestation and the hemoglobin level is less than 7 gram percentage without any signs of cardiac failure or hypoxia, severe anemia is there, then we have to go for the blood transfusion. So this is all about the antenatal period as per the FOGSI. Less than 34 weeks of pregnancy with less than a 5 gram percentage of hemoglobin, and more than 34 weeks of pregnancy is less than 7 gram percent of hemoglobin without any cardiac failure or hypoxia. The woman is having anemia, so you have to go for the blood transfusion. Okay. Now come to the interpartum. FOGSI is saying that during interpartum period, if the hemoglobin level is less than 7 gram percentage, blood transfusion decision has to be made by the obstetrician or the medical personnel in the team. In case of postpartum period, if the woman is anemic, okay, there is a with the sign of shock or hemorrhage, or there is a hemodynamically instability in the woman, and the hemoglobin is less than 7 gram percentage, the blood transfusion decision has to be taken by the medical personnel or the obstetrician present over there. Okay, so these are the three category: antepartum, interpartum, and postpartum. As per the FOGSI, I have told you about the indications of the blood transfusion. Now come to the management of severe anemia during the labor. So the woman was in the antepartum period. Now the woman is in a interpartum period. I mean the woman is in labor. So how will manage? So during the first stage and during the second stage, like that I will divide and explain to you for your easily understand. Okay, so in during the first stage, what you have to do first? You have to counsel the woman and the family member first about the condition and the consequences of this anemia, because we know that as a complications of anemia, the PPH can lead easily. If it is less than 8 gram percentage, a woman can easily lead to PPH. What are the risk factors I have discussed? If anything has present, or the woman is already diagnosed with a severe anemia, you have to counsel the woman and the family first and let them know the consequences of this anemia, what can happen and how we can going to manage if it is happening. Let them ask for a range of blood as early as they can do that. uh, ask the woman to sit in a propped up position so that she will not having any breathing difficulties, and give her oxygen, okay, as per her need. And then minimize the vaginal examination. First, it will induce the infection first, and second, it is painful, so she will have more palpitation and the breathlessness and the problem difficulty in breathing, so that will again leads to problem. Then monitoring for the sign of cardiac failure. So you have to continuously monitor a severely anemic woman for any sign of cardiac failure, any sign of shock. So go for the checking of blood pressure, pulse, respiration, SpO2, okay, and intermittently do the chest auscultation to understand if there is any deviation from the normal present or not. Fluid restriction has to be done. Fluid restrictions will go for the cardiac overload, and that can go for the cardiac failure or the others problem. Okay, then we can start the antibiotic prophylaxis beforehand, and blood transfusion under the diuretic coverage we can go for. Okay, so these are the management during the first stage of labor. During the second stage of labor, what you can do? We can go for the prophylaxis of ventos or forceps with the indications of, rule out the indications of episiotomy. As this is the assisted birth, to shorten the second stage of labor, we have to go for the prophylactic assisted birth, like applying of forceps or the ventos, okay, and rule out the episiotomy and then give, okay, and cut short the second stage and ask the woman for bearing down, okay, and try to assist the woman in a proper position when she is giving birth, or any upright position she is giving birth, to her baby, because with the gravitation and with the propped up positions, on any propped up positions or any upright position, the woman's pelvic outlet diameter will be more, and the second stage of labor will be reduced by time, because the baby is easy to baby will easily come, as because the outlet of pelvis is opened up, okay, by the position changes. And restrictions of the IV fluid, the woman can take sips of fluid if it is she is trying for the normal birth, okay, she can take oral sips of fluid, but IV fluid has to be restricted. So these are the second stage management during the labor. So these are the management that I have discussed about with you. Now come to the most exciting part, that is prevention. So prevention is starting very earlier. So prevention has to be started in the adolescence period. It's not before the pregnancy. Just if any adolescence is anemic before pregnancy, you have to resolve the problem. First one, how you can do that? Dietary management, deworming, any undercause medical indications, have to treat that, okay. And the woman has to start IFA, that is iron and folic acid supplement, during her adolescence period or pre-pregnancy period, so that she can recover her body from the anemic state. First prevention. Second prevention, when she's uh, pregnant, give proper diet, I mean the iron rich diet along with the vitamin C rich diet. Second. Third one is give the iron supplement when she is just crossed her first trimester. So from 12 to 14 weeks of pregnancy, she can start the iron folic acid supplement every day without missing, proper time with vitamin C rich food, okay. This is the third one. Fourth one is deworming, proper time. Deworming universal. So when you are recommending albendazole 400 mg, you have to be give to all the women as a prophylaxis, because universally it has to be given as per the recommendations, okay. So these are the preventive measures you can do. Now come to the role of a nurse or role of a midwife. What you can do that? First, rule out clinically, because you have your clinical eye to judge this woman is anemic or not. Secondly, when the woman is coming for the visit first time, give the test for hemoglobin and the CVC both, to rule out in the first trimester itself she is anemic or not. What is her hemoglobin level? Again, don't forget to check, as it's your role at 24 to 28 weeks of gestation, and again in the last trimester and the 36 weeks of gestation. Fourth point of your role is, if the woman is found out or diagnosed as anemic, so you have to check the hemoglobin in every visit, and she should not miss any visit. She should not miss any visit as per your recommendations. Fourth one is, counsel the woman about the signs and symptoms, what can happen suddenly. Ask her about the signs and symptoms, what she is feeling or she is having, and as per that, you have to just change the doses. Generally, IFA tablet the women are taking once in a day. But if the woman is find out with a mild anemia, she can start the tablet twice a day, BD. Okay, so she has to take 2 times in a day, in empty stomach preferably, or after 2 hours after the meal, and at least 4 hours gap before taking the calcium. Okay, so these that you can take. You can manage in antenatally, you can manage internatally. I have discussed about the points internatal during the labor, what you can do management. You have to do all that points as a nurse's role. And postpartum period, you have to counsel the woman to continue the same tablets for at least 100 days or 3 months as per the, or 6 months as per the recommendation of Ministry of Health or the government of WHO or the government of India. So these are the roles of nurse that you can do. And the last one what you can do is that continuously counseling the family members and the mothers about the baby outcome and the mother's outcome, so that if suddenly PPH happen as a complications, they will not worried that why it suddenly happened, because they are prepared that these are the things can happen. So these are the counseling you have to do for the family members. So these all about the iron deficiency anemia and the other causes of anemia during the pregnancy. Hopefully this video is very helpful for you and for your exam, because it's a very common topic coming in the exam, either practical or theory, and the most common medical conditions where you can find the woman coming to the antenatal OPD for the visit, or the woman is coming in the antenatal ward directly without any checkup. First time she is admitting and she is anemic, so you can manage and you can understand what are the things you have to do and what not. Okay, so in today's video I have discussed about the management of iron deficiency anemia, the prevention, and the role of nurse or a role of midwife in a very depth. Hopefully, part 1 of iron deficiency anemia and part 2 of iron deficiency anemia, both video you will watch together to make your notes for your competitive exam, for your nursing exam, or for your clinical field. If you found this video was helpful for you, please like, subscribe, and press the bell icon so that you will not miss any notification further from our channel. Till then, stay tuned. Bye.